session two. And session two is enhancing preventive services use in the backdrop of, get this, Braidwood versus Becerra. This is a hot, very important policy issue. There's a lot of political, economic, maybe even sociocultural flack about this one, and people are watching this very, very carefully. Clearly, in the VBID world, what the Affordable Care Act called for preventive services is central. And we really want to take a very careful look at this. And we're very pleased to have Adnan Parek and Nick Bath to weigh in on this for us. And as we did before, Adnan, followed by Nick, could you just remind us sort of your name, title, affiliation, and how it is you have a connection to this issue? Adnan.
Cliff, thanks so much. Great to be with you and great to be with Nick on this panel. My name is Anand Parekh. I'm the Chief Medical Advisor at the Bipartisan Policy Center. We are a nonprofit think tank, sort of a U-tank that tries to take the best ideas from both sides to promote health security and opportunity. I provide the clinical and public health expertise of the organization. And I think for those who know me, just to in 30 seconds, or I've spent my last, I'm an internist, primary care physician by background, but spent the last 20 years in the executive branch and now here at the Bipartisan Policy Center focused on Congress, really focused on what I call the 4Ps. So if you want to improve population health, you got to really invest and prioritize prevention, primary care, public health. And so this idea of sort of access to clinical preventive services, evidence-based ones, high-value services, has really been core to a lot of my work and really the leadership of the VBID team and Dr. Mark Fendrick, working with them has really brought me to today's webinar. So thank you, Cliff.
Thank you, Anna, very much. Nick, over to you. Name, rank, serial number, and how you are in this, your connection to the issue.
Hi, everyone. Thanks so much for having me. It's great to be on this panel with Anand, and thanks so much for Mark for including me. I am currently a partner at Manat Phelps and Phillips, part of the health practice here. Before I've been here for just over a year. Before that, I worked in health policy in the Senate for almost 17 years. Basically, all of that time with the Health Committee. I started on the Health Committee with Chairman Kennedy and worked on the drafting and passage and implementation of the Affordable Care Act. After he passed, Senator Harkin took over the committee, worked for him, and the last 8 years I managed the healthcare team on the Health Committee for Patty Murray from Washington State. So I've done a lot of work, and you know, I should give a shout out to my previous panelist, Katie Spangler. We worked closely together during those 20 teens years, and so happy to have her involved in this space. You know, working for Tom Harkin, the value of prevention and the importance of preventive services were sort of hammered into my head every single day. So great to be here.
Nick, is part of your job tracking things like Braidwood? And do you have any particular role or stance or clients engaged here? Just want to understand where you are relative to the issue.
No, sure, great. Thanks so much for that. I should have mentioned that at the top. You know, I work on a lot of the. We have a lot of clients here who are very focused on you know, sort of the federal insurance market regulation and the commercial market, both plan and health system side. You know, I've also, you know, we're also trying to work together with Mark and others, I'm sure, on this call, as well as, you know, private sector stakeholders to put together sort of coalition of the willing on possible legislative solutions to the Braidwood case. So feel free to reach out to me after this call or anytime if you have interest in that.
Thank you very much. So on back to you. You're a researcher, you're a doc, you've got several kinds of interests, certainly in value-based insurance design and so forth. What's your set of perspectives vis-a-vis the role of Braidwood versus Becerra and your outlook? Can you kind of give us 8 or 9 minutes on that?
Yeah, well, so I'll make just four, I think, initial points, and then I'll turn it over to Nick to talk a little bit more about the court case and where it is right now and where it's headed, the implications, and perhaps where it may go. But just a level set clip, I think, for our audience, and I think, uh, um, I think most of the audience, knows this, but I am still often asked here in DC, does prevention work? And let's just focus on sort of the clinical piece here. As you all know, there's a tremendous evidence base with respect to clinical preventive services. So whether it's immunizations or cancer screenings or substance use counseling, sometimes they don't work as well as we'd like, but there's absolutely a tremendous amount of evidence. There are also rankings out there, not only bodies like the U.S. Preventive Service Task Force that recommend services, but also bodies that sort of ranks a lot of these services based on how much of the clinical burden does it prevent, how cost effective are they, and services like childhood immunization, screening and counseling for tobacco and alcohol use, colorectal cancer screening, cervical cancer screening. All of these are just examples of really high value evidence-based preventive services. All of them have sort of a different sort of benefit potential, if you will. Some of them may save money. Most of them don't save money, but they're really cost effective. And so that's sort of just a level set that this really matters. These services save lives, they improve health, they reduce illness burden, and they really work. And so I think that's sort of the first level set. I think the second point I just want to make at the outset is, in spite of them working, our uptake rate in terms of what is recommended for Americans, we are not doing great. In fact, we do pretty poorly. Now, all services, are a bit different when it comes to, let's say, cardiovascular screenings. We do pretty well. About 70 to 80% of Americans are up to date with the cardiovascular screenings that they need. Cancer screenings, a little bit more variability, 60 to 70%, depending on whether it's breast cancer, cervical cancer, colorectal cancer. But then when you get into, let's say, substance use, mental health, depression screening, SUD screening, counseling, we drop to like 30 to 40%. Immunizations are really all across the board. And we know with sort of the recent politicization of COVID vaccine that, there have been some spillover effects. So depending on the service, certainly the uptake rate change, but as a whole, I think it's fair to say we really don't do as well as we need to. And then if you look at it another way, and this is data from MEPS, which is the Medical Expenditure Panel Survey. If you ask the question, adults over the age of 35, how many people are up to date with everything they need? It's less than 10%. So the last count was about 8%. So 8% of Americans, adults, being up to date with everything that they need in terms of evidence-based preventive services. And certainly, if you're insured, that rate is higher than uninsured. Higher income, that rate is higher than lower income. Urban areas, higher than rural areas. So there are some sort of disparities there. And so that brings me sort of to the third question. This is not a new issue. We have had sort of low uptake of high value evidence-based clinical preventive services for a long time in the commercial sector and Medicare sector. And so the question is why? And so there are lots of reasons for that. So, at one point, it was a bit of a knowledge gap. I think most healthcare professionals know that these are important, but the knowledge gap has been there. Provider priority and systems of care has often been an issue. Particularly, this relates to how we pay for primary care, how we create teams and provide team-based care. So systems of care often get in the way of the provision of evidence-based services. Quality metrics. So we know that quality metrics are, in fact, the currency now that drives value-based healthcare transformation, or what we hope is increasingly value-based healthcare transformation, and quality metrics matter there. And there are questions of how well we prioritize those quality metrics that relate to clinical preventive services and the provision of those services, and have we elevated them enough? social needs. So from the patient perspective, it takes time, energy to really get these services. So do you have the transportation? Do you have the time? Can you get off of work? Do you have the leave? And then finally, I think, and this is at the heart of our conversation, costs, right? So, and this goes squarely into VBID, and this is squarely what Section 2713 of the Affordable Care Act was really all about, and what Dr. Fendrick and so many of you tuning in today worked so hard for those things that work and that work well and that have tremendous evidence for. Let's reduce that cost sharing burden. And that's what the Affordable Care Act did for recommendations from the U.S. Preventive Service Task Force, from the Advisory Committee on Immunization Practices, from HRSA's Bright Futures guidelines for women and children. That's what it did, and it has worked. If you look at data over the last 10 years since the Affordable Care Act, removing cost sharing from these preventive services has led to increases in screening for colon cancer, for high blood pressure, high cholesterol screening, vaccinations for the flu, for HPV, and the use of contraception. Not only that, it has particularly the use of preventive services increased amongst those who are financially vulnerable, as well as in minority populations. So this matters, and we know that it likely matters, but there's evidence to support that. And I think that's what maybe, and this is sort of a good segue to Nick. I think that's what makes this case, Braidwood versus Becerra, so important, because we know that these are really impactful services. We already don't do very well. The pandemic, by the way, put us even further behind. And here we are trying to really raise uptake, save lives, in some cases, moderate costs, in some cases, reduce preventable healthcare costs. And now, removing this cost sharing burden, which was the appropriate policy, now may be into jeopardy. And I think that is really the risk and the concern here, Cliff. So maybe I'll just stop there. That sort of sets the stage for the actual case, and then let Nick go, and then we'll happy to engage in the discussion.
Now, Anand, just before we do that, though, from the standpoint of a clinician who has studied this and who has outlined very nicely, very clearly, the upside of providing these preventive services with no cost sharing, if the Braidwood plaintiffs prevail in removing the requirement for insurers to provide these preventive services at no cost, do you see a distinct potential for a drop-off in these preventive services? Is that sort of a cloud hanging over us at this point? Do you foresee a significant impact clinically?
Yeah, worst case scenario could be back to the Wild West, right? So depending on the insurer, the plan, the purchaser, who is paying, they could then set their own rules and guidelines. Now, I think, one of the good things here, the good signs we've seen from a lot of the major plans is they support this. They see the benefit for their members, and they continue to advocate and support these services, and people removing, obtaining them without cost sharing. But yeah, I mean, worst case scenario, we could go back to the days where I may recommend, as a clinician, it's now important to get your colorectal cancer screening. And the response might be, well, I don't have the $500 to pay for that, and that's exactly what we were trying to get away from with this ACA provision.
Yeah, it just seems that given the kind of frequency of migration from health plan to health plan in the United States, kind of a continuity of preventive services could be at risk, given that some plans might continue to cover and some might not. But it is good. There's some amicus briefs and so forth from the insurance industry that have kind of weighed in, which are helpful.
Yes.
So Nick, where do we then stand? I want kind of a policy kind of take on this and a DC insider look. What do you have?
Sure, sure. Well, just picking up from where Anand left off, just and just quickly flashing back to 2009, 2010, which Mark and many others on this call were involved in. To Anand's point, the goal of the preventative services provision in the Affordable Care Act, from the beginning, the earliest days of its drafting, all the way through the final product, obviously, was to reduce cost barriers as low as possible for those interventions which have been shown in the long run to save downstream healthcare, uh, the health and healthcare costs. And the construct, the structure of the legal protection delegated authority to the United States Preventive Services Task Force to require commercial plans to cover with zero cost sharing A and B rated services by that independent scientific body. And, I think it's worth pointing out that the reason for that delegation of congressional authority to that body was to insulate it from political pressure or the appearance, right, of political influence. And, I think you see similar attempts on very sensitive issues in other areas of the law. For example, the Essential Health Benefits Package, which sets a sort of a baseline benefits package for all commercial plans. So fast forwarding, where those efforts to insulate that process from either the reality or the appearance of political pressure have become its Achilles heel. And so, the plaintiffs in the Braidwood case, which I'm sure everyone's familiar with here, so I won't dwell on too much, but sued in a friendly district court that had been the forum for other ACA-related lawsuits, alleging that the preventative services provision in the ACA was constitutionally unsound under the Constitution's appointment clause. And without getting all Larry Tribe on everyone, the appointment clause requires certain officials who perform certain functions to either be appointed by the president or confirmed by the Senate or appointed by a cabinet secretary. And that depends on a finding of whether they are a principal officer or an inferior officer. And setting that aside for a moment, that is sort of the core argument that has succeeded thus far at the district court level and appears poised to succeed in the Fifth Circuit Court of Appeals, which just had an oral argument on March 12th or something like that, if memory serves. No, not March 12th, earlier this March 4th. And there is a subsidiary argument where the district court held that the court held that the plaintiffs prevailed on that score. And so it's not that the USPSTF can't look at preventative services and evaluate them. It's not that the USPSTF has no power. It's just that they don't have this specific power to deem certain preventative services as requiring no cost sharing in the commercial insurance market. So the practical impact of the court's decision, were it to go into effect, and it is currently under stay, would be to allow cost sharing for A and B rated services if the USPSTF acted on those after the date of enactment of ACA, which is post March 23rd, 2010. So we're coming up on the 14th anniversary here. Now, there is a sort of a subsidiary argument I'll briefly mention, which uses as its statutory head or authority the Religious Freedom Restoration Act, in which the plaintiffs challenged the USPSTF's recommendation to cover HIV pre-exposure prophylaxis, or PrEP, as a zero cost sharing item. District court held that violated the religious freedom of plans in some cases under RFRA, under that federal statute. That is also on appeal.
So certain plans that have some religious connection would, because of that theology, I guess, they would say, a fair objection to offering PrEP for people at risk of HIV. And that's that particular challenge. But Nick, just back, the plaintiffs here are questioning not the expertise, but the authority of the members of USPSTF and the members of ACIP to have this basically what they interpret as an executive authority to say yay or nay on coverage for preventive services. And they're saying that's not their job, that would be the job of what, Congress?
That's right. I mean, there are several ways, and that is a great segue to sort of the recent Fifth Circuit oral argument. The Fifth Circuit has not issued a decision, but the oral argument certainly implies that they will, I think a betting person would say they're inclined to uphold the district court ruling on both counts, both the Appointments Clause violation and the RFRA violation. And much of the questioning during the oral argument surrounded what remedy the court should prescribe. And so, given that they sort of, for example, issue a nationwide injunction on a requirement on these, the requirement that currently applies to plans, simply declare it's unconstitutional and allow plans to do what they will. So, the fact that the argument focused on what the remedy should be isn't a great sign on the merits.
All the attention to the remedy suggests that they're looking for not rejecting Braidwood, but doing something about it.
Right. It seems to me that they've made their mind up on at least the Appointments Clause argument. Now, the question, of course, then arises, well, how does one cure the Appointments Clause issue, assuming that the Supreme Court will be in a similar place as the Fifth Circuit in its analysis? And before jumping to that, however, I want to say that many folks who are deeply invested in the importance of this statutory mechanism, do not believe that the Supreme Court should be taken for granted in this context. So I think, very important that we clarify that, that we have a federal appellate court system. The Supreme Court has not been heard on this issue if they decide to take it up. And the Fifth Circuit is expected to make their decision sort of by the end of the year. There's an additional step that could be taken. If the plaintiffs prevail, the government could appeal to sort of the full Fifth Circuit. This was a 3-judge panel. That's known as an on-bank hearing, or they could appeal directly to the Supreme Court. So that's sort of where the current legal arguments stand. I think I will say just a small bit of editorializing that in this one, there are many observers, this one included, who think the Appointments Clause argument is a pretty uphill battle. And so using that as a sort of segue, to, well, if one were to consider what a solution would be, that solution would generally have to be legislative. As a side note, the Secretary of HHS did, during the pendency of the case, appoint the USPSTF members under his own authority, under his appointment authority, under a fairly esoteric statute. It seemed in the Fifth Circuit argument that the judges did not buy that he had the power to do so, which would again sort of put the ball squarely in Congress's court. So what does that look like? I think while the actual language of such a change would be fairly elegant and straightforward and quite short, the language and the substance isn't particularly the challenge. It's obviously the cause itself and its political viability. And so I'll just list a few things, which I think hopefully will provoke some discussion, which is many of my colleagues have talked about before. On the pro side, for reasons for optimism that there would be bipartisan support should a fix be required, there's the obvious popularity of these and health enhancing effects of these services. I mean, they've basically instantiated themselves. They're baked into the cake now. No one expects to pay for these.
They're de facto working. They're de facto admired. People like it.
That's right. That's right. And we've seen, if anything, over the last 15 years plus has taught us that people don't like it when you take away something they already have in healthcare, especially. The duration of their use, I think, militates towards optimism. They've been in, it's not like this was just a couple of years. I mean, they're well instantiated into both the provider and the patient community's expectations. There's lack of concentrated, powerful opposition, the lawsuit notwithstanding. There's not, in my view, there's not a well-funded, well-resourced, loud lobbying coalition seeking the outcome that the plaintiffs in the case are seeking. And finally, I think maybe one that's a little bit underreported is sort of flipping the intention of the original law on its head into an advantage, which is that fixing this problem would make the process more politically accountable, right? If the intention of the original provision was to shield the process from political pressure, sure, this would open it to political pressure, but it would also open it to light, transparency, and accountability. However, there are some obstacles here. The very duration, the length of time that these benefits have been in existence, and the fact that they disappeared from your out-of-pocket liability makes them somewhat invisible. That is, just to put it simply, people take them for granted and may not know where they came from. In fact, probably don't. There's very little cost savings associated with them. This is a fairly technical legislative reason. But for a variety of reasons, the Congressional Budget Office is loath to assign this policy large downstream federal savings in the form of avoided medical care, for example, for Medicare beneficiaries. Why? It's a complicated explanation that I would be happy to talk through more, but one of the reasons is that CBO has an assumption, which has been difficult to dislodge for some time, that without the legal requirement, plans will cover these services at zero cost sharing anyway. Now, I think
some suggest that they might, right? There's some evidence that indication at this point that they would be willing to, right?
That's right. That's right. They do. And I think that's important and laudable, and obviously good for people's health. I think what it misses, however, is that, the technology of preventative service development isn't static. And what happens when a screening test for cancer arises for which the price is something unexpected? I think then the plan and self-insured dynamic may look a little different because they have fiduciary duties, not because they're bad people.
Well, it's interesting, Nick. We've already had a question about things like liquid biopsies and so forth. So some screening technologies that are in the pipeline
exactly
could be very, very expensive. Now, that all depends on the evidence of safe effectiveness and kind of diagnostic screening accuracy and so forth that would play out. Nick, I really like your point about, you called it empirical instantiation, which would kind of help support this. Question for you, maybe a little subtle, and this arises from a question we had earlier, and that is, these groups, the U.S. Preventive Services Task Force, ACIP, and the people that take a look at this on the behalf of HRSA, these groups were not established to tell insurance companies what to do. They weren't established for that purpose. They happen to be looking at the evidence pertaining to these preventive services. They've already been doing it for years. Congress didn't say that they're going to make the decision. Congress simply said when they have a recommendation, as per the ACA, then Congress requires that those services be paid, be reimbursed. Right. So it's not like ACIP and USPSTF are the executive authority here. They're scientific experts, but there's a law in place to say, by the way, if these people give it an A or a B, insurers got to pay for it.
That's right. It's like a self-executing statutory mechanism. That's right. It's not like the people at the USPSTF have a gigantic signet ring that they
Right.
stamp onto all insurance plans once they make a decision. They just make decisions like they always have.
Right. So Nick, play this out for us if you don't mind. Then I'm going to ask Anand for his clinician's response here. What, as of 14 March 2024, do you or are you willing to project or forecast a most likely scenario here? I think I kind of got a little drift of it from the business about the appointments clause being a tough one to overcome. Less know about RIFRA. What do you think is a most likely scenario here for this to play out? If you had to pick one.
Yeah, I think I do think that after a long period of appeal, which could take to the end of next year, that the appointments clause issue is going to be in Congress's court.
Mm.
I think that's going to be a challenge for some of the reasons we described, an opportunity for other reasons. One just to finish one thought, the question we were talking about CBO not scoring savings because they believe plans might cover this anyway. Plans announcing that in spite of Braidwood, they're going to cover these services with zero cost sharing is obviously great for people's health. It's also difficult for the political urgency of the cause.
It undermines it,
As
doesn't it?
members who might otherwise be disinclined to take a walk out on a unsteady plank of Affordable Care Act bipartisanness might say, well, I don't need to do that because it's going to take care of itself here in the marketplace. So, I think there's some cross-cutting dynamics here. The only other one I mention is that there's sort of in the current divided government, and we'll see what holds in the next presidential term. There used to be, during the lame duck session, not to get too inside the Beltway, which is the period of congressional session after an election, a November election, was often a time when small technical fixes like this could be done in a less politicized atmosphere. I think that, the current dynamic, especially in the House, makes it difficult to project, much more difficult than in previous Congresses, whether a lame duck will exist as a legislating opportunity.
Mm.
That's an uphill battle. And finally, I think the Affordable Care Act's political potency, which in recent years has declined significantly as a force for political gain or loss, is still unclear. And I think with that lack of clarity, there's some people don't want to take risks if the risk-benefit analysis isn't clear.
Got it. So, Nick, play it out for us. I know you weren't avoiding my earlier question because I know you wanted to make those 2 points, but what's the most likely way this plays out if you had to predict?
Yeah, I mean, I think that there would have to be a bipartisan agreement in both the House and the Senate that there's a very clear rifle shot statutory fix here, and that also an agreement that there would be no need to weigh down, freight, sort of Christmas tree this change with other unrelated policy changes. And I think that last part is the hardest part. I mean, the one that just comes to mind from my recent time is obviously, reproductive health politics are extremely sensitive and extremely powerful for good and ill, and it's often extremely difficult to avoid them in a moment like this when there's a legislating opportunity.
No kidding.
So I think, moderate members on both sides, just to answer your question directly, come together, sponsor a bill, introduce it, shepherd it through committee, try to play keep away and reduce any controversial attendant matter, and attach it to a moving vehicle in 2026. I mean, that's my best.
Okay.
That's my best sort of scenario planning there. But yeah.
Well, we'll take that from you. So Anand, Nick just kind of explained a lot of the intricacies, and then we kind of got him to sort of project a possible scenario. How are you feeling now? Are you more or less confident? Are you going to be talking to your insurance companies about coverage if things don't go the right way? And by the way, let's not forget, because I know you're associated with Michigan, VBID Center co-authored this provision, this very provision of which we speak. And so depending on how this thing plays out, one might expect VBID to take one or more stands on a few issues. In any case, on what's your take now?
Yeah, so thank you. No, it was great. A couple of reactions to Nick's comments, and then sort of what I think we need to do in the interim while this all plays out in the courts, and then potentially legislatively, as Nick articulated. The first is in my conversations on the Hill, and sort of what we do here at BPC. I haven't run into any offices that really want to do away with this provision, right? And I think to your point, Cliff, if you poll this, Republicans, Democrats, if you ask members, I think in theory they're supportive. They're supportive of preventive services. So I do think this is a bipartisan issue. I think that's sort of the first. The second is, and we've seen it in their statements, but I do think that a lot of the big plans purchasers out there, they're committed to this as well, regardless of sort of what happens with the case. That being said, not everyone in America is employed, by a big employer and so if this goes away, you could lose that uniformity, and there could be a lot of people who might not be able to access these evidence-based services without cost sharing once again. So it does become a little bit of an uneven terrain. The third thing, just sort of a footnote on the CBO, and I'm not sure if this was ever thought to or overall save money. I mean, in most cases, prevention, certainly probably a minority of services could save money, but they are truly cost effective. That being said, I do think that there is some movement for CBO to start broadening their 10-year scoring window to look at a 20 and 30-year scoring window when it comes to prevention. There's a bipartisan bill that actually just passed the House Budget Committee, a 30-0 vote, you hardly get these days, on what's called the Preventive Health Savings Act, which would essentially say, hey, when it comes to these kinds of issues, CBO, just don't look at your 10-year scoring window, look at it 20 years, 30 years. And I think for prevention in general, that would be impactful as Congress looks at these issues. But I just wanted to point that out.
Those are very helpful.
I think, Cliff, so Nick put out there 2026. So I think that the key point I want to communicate is, well, if that's the case, what should we be doing over the next 2 years? I mean, there's sort of the policy track, and I think we need to focus on that. And if the courts go one way, and how do you legislatively fix it? But the fact of the matter is, again, as I said, uptake rates are really, really low. And what can we do in the interim from a health perspective to try to make sure that people understand and are able to access the services that they need? And what I do think we need in parallel to the actions that Nick articulated is we need a national campaign to increase uptake of clinical preventive services. And we need payers, and we need employers, and we need provider groups and patient groups and communication and media and government agencies, and irrespective of administration, we need everybody to really come together, increase education, increase awareness, make sure that people understand this. Again, as I said, we got even further behind after the pandemic. But this is something we can all rally around. Who's going to be against this, really? And while we wait for all of this to really, sort of the end game here and what happens with the courts, let's not lose any time. Let's all, from a science perspective, communications perspective, let's all build a coalition to really promote and raise awareness and educate Americans Clinicians play a big role, but it's a lot more than clinicians. It's
Yeah.
you need other well-known people out there and role models and folks who people look to. They can have a big role as well. But we really need a multi-stakeholder coalition again while we work the policy track to really try to increase the uptake rate. So that's what I think we also need.
Well, points well taken. Trying to increase the uptake rate for clinical and epidemiological reasons is certainly laudable, but trying to do that against the backdrop of uncertainty with this particular case, and even if the case goes the way that Nick kind of predicted, that does introduce some uncertainty. And I would think that many of your patients, Anand, are among the tens of millions of Americans whose coverage is, if not entirely at risk, uncertain insofar as its scope with regard to primary prevention and so forth and other services.
Yeah.
And without this requirement, there are a lot of potholes on the way. And this could be, yeah.
Yeah. Well, fortunately, as Nick said, there's a stay right now. And
For
so
now,
again,
right.
My point is, regardless of which way this goes,
Still,
a campaign, whether it's addressing some of the other non-cost barriers, whether it's just, helping providers with systems of care and quality metrics, whether it's educating the public, there are a lot of things that we can do while we continue to focus on the policy track to fix this, and if it needs to be fixed, that we can do to again increase access to services and improve health.
Point well taken. It would seem that VBID and its stakeholders and partners have more on their plate now, if you don't mind my saying. VBID, like we said, co-authored this provision. It's now, shall we say, in flux, and there are clinical, economic, and political arguments to be made. I must say that a couple of our questioners really are kind of focusing on the politics of this. One person said, hey, was there much pushback against USPSTF AB ratings before PrEP was included? And the questioner is sort of suggesting that the issue around PrEP with the politics and the theology may have attracted folks to kind of knock down the whole provision, but that the PrEP issue might have kind of energized that. And then Catherine McLean makes a very strong case in her comment, rather than question so much, is that she's skeptical that all plans will in fact cover these services without a requirement, because members can move from one plan to another and not want to help their competitor. Before the ACA, plans understood that these preventive services were net good, but individual plans did not have certainty that they were good for particular individual plans, specifically because if other plans did not cover, they would have additional medical expenditures and so forth. And she went on to say, after ACA took effect, plans were happy to cover these because it was a level playing field relative to their competitors. And so there's some strong market issues here that might mitigate against a favorable or optimistic assumption about widespread planned coverage of these things. Okay, last word. Anand first, and then Nick. What's your single most important take-home point for us as we look ahead to how Braidwood versus Becerra plays out? You can go clinical, you can go economic, you can go political. Give us the last word, Anand.
I mean, I think, look, and Nick alluded to this. I mean, and I, thought a lot about this, written a book about this. When it comes to prevention, oftentimes, we take it for granted, right? Because the wins are often invisible, what we're averting, what we're preventing. And at any given point, there are dozens of issues that we could be working on, we are working on, but I really urge all of yours to really, make this one of your top priorities, really hone in on this. I mean, at the end of the day, we all care about health, and these are services that save lives, they improve health. And so while we wait for, again, everything to materialize with the court case, understanding what each of us can do, whether it's, plans or clinicians or patient groups. I think everybody's got a role here, Cliff, I would say, to ensure that we can increase these, uptake these high-value evidence-based clinical preventive services.
Point very well taken on. Nick, you got the last word on this. We kind of squeezed out of you a prediction. I don't know if you want to double down on that or have another closing comment. What do you have, Nick?
No, I just want to echo what Anand said, which is I think, to some extent, I mean, the need to build broad political consensus around a clean solution to this issue is very, very high. And I fear that sometimes this issue is sort of a victim of what I'll call the inbox checklist, which I don't know about you, like I sort of use my Outlook inbox as a to-do list, right? But once it falls outside like the first couple of scroll pages, is it really a priority anymore? Does it really exist? And I think that healthcare organizations, profit and non-profit, for-profit and nonprofit, and foundations have a lot of things they care about. And it's without any judgment, it may be possible that with all the things we have to think about these days, this issue is maybe 6, 7, 8, maybe 11 on our list. And I think if we continue down that path, we're going to get to a point where we realize we haven't sort of, to Anand's point, built the foundation consensus, bipartisan consensus foundation necessary to proceed.
This is a cautionary point. Anand certainly doesn't put it 6th or 10th or 11th on his list. I think we can agree on that. Well, Nick, thank you both very, very much. You brought kind of the clinical expertise, the legislative policy expertise. You sort of integrated those very clearly. We need to pay attention to this. And I must just say as an editorial note, the VBID Center can't like disappear from this, and the VBID Center needs to stay at or near the center of this issue. And I, for one, hope that they will continue to do so. Okay, thank you both very much.